Let me start with a case because it still bothers me. A patient comes into the emergency department with a red, painful lower leg. Looks like cellulitis. Someone runs the LRINEC score, plugs in the 6 labs, and it comes back at 4. Below the cutoff. Low risk. The patient gets sent home on oral antibiotics. 36 hours later they're back, in septic shock, and in the operating room with necrotizing fasciitis.
And that right there is the trap this score can set. So today we're doing something a little different. Think of this as a cold case. Back in 2004, we got a verdict, a scoring tool that looked airtight. And for 20 years, people have quietly been trying to reproduce that verdict and failing. I want to walk through the evidence like it's on trial.
So set the scene. Where did LRINEC come from?
2004, Wong and colleagues in critical care medicine. The laboratory risk indicator for necrotizing fasciitis. 6 routine labs, C-reactive protein, white count, hemoglobin, sodium, creatinine, and glucose. You add up points, maximum 13, and a score of 6 or higher flags you as intermediate to high risk for a necrotizing soft tissue infection.
And in that original paper, it looked spectacular, right?
Spectacular is the word. In the derivation and validation cohorts, the area under the curve was around 0.98. That's nearly perfect discrimination. Positive predictive value, 92%. Negative predictive value, 96%. If you only read that 2004 paper, you'd think we'd solve the problem. Departments adopted it everywhere.
So here's my job today. I'm the investigator, and I've gone back and interviewed every witness since. And Dr. Z, the witnesses do not agree with the original verdict.
Lay it out.
Start with the big one. The largest and most authoritative meta-analysis, Fernando and colleagues in Annals of Surgery, 2019. 23 studies, almost 6,000 patients. At the positive threshold, a score of 6 or higher, the sensitivity was only 68%.
68. So roughly 1 in 3 true necrotizing infections has a score that doesn't cross the line.
1 in 3 missed. And it gets worse. If you use the higher, more specific cutoff of 8, the one people reach for when they want to feel confident, sensitivity drops to 41%. That is worse than a coin flip for ruling anything out.
And I want to underline what sensitivity means here for anyone half listening. A low sensitivity test cannot rule the disease out. A reassuring LRINEC does not make necrotizing fasciitis less likely in any way you can trust. Keep going. Who corroborates Fernando?
3 independent witnesses, 3 different parts of the world. A Taiwan validation, Liao and colleagues, sensitivity 59%. An extremity-focused meta-analysis, Terracone, sensitivity 49%. And the one that really gets me, a German level 1 trauma center looked back at 70 patients with histologically confirmed necrotizing fasciitis. 37% of them, 26 real, biopsy-proven cases, had a low-risk score under 6 at presentation.
Confirmed disease, reassuring score in more than a third. That's the whole case in one number.
Now, in fairness, the defense gets to speak too. There's a 2025 paper from Japan, a recalibrated version called LRINEC that pushed sensitivity up to around 91%.
And that's genuinely interesting, but I tell a resident to pump the brakes. It's a single-center tool, not externally validated yet. And notice, even the people rebuilding the score are implicitly admitting the original doesn't work. The deeper lesson doesn't change. Labs lag behind tissue. The necrosis is happening in the fascia hours before your C-reactive protein catches up.
What about physical exam, though? Don't we lean on the classic signs?
That's the other myth this same meta-analysis punctures. Hemorrhagic bully, the finding everyone pictures, had a sensitivity of only 25%. Fever, 46%. So no single lab, no single score, and no single physical sign safely rules this out. They can raise your concern. None of them can lower it enough to relax.
So, what actually is the safety net?
Surgical judgment and time. If your gestalt says this could be necrotizing, pain out of proportion to the exam, rapid progression, systemic toxicity, a patient who looks sicker than their skin, you get surgery to the bedside early. Serial exams. A low threshold for imaging and, more importantly, for operative exploration. Early surgical consultation is the intervention that saves the limb and the life, not the score.
So the verdict on the cold case?
The 2004 verdict is overturned on appeal. Use LRINEC the way it was actually meant to be used, as a tiebreaker that can push your suspicion up. A high score should make you move faster, but a low score is not an alibi. It should never talk you out of calling the surgeon.
Bottom line for the wards. If you're standing at the bedside thinking this might be necrotizing, a normal LRINEC does not change that thought. Trust the clinical picture, get surgery involved, and don't let a reassuring number be the reason you waited.
Well said. Use the score to raise suspicion, never to lower it. That's the episode. Next time, we're switching gears to a genuinely new class of pain medicine and asking whether it lives up to the headlines.